cancer diagnosis is enough to rock anyone's world. Now imagine this. You find out your chemotherapy drugs weakened your heart. The risk factors of cancer every woman needs to know. Good morning. I'm Jessica Lovell in for Alexis Del Cid. Welcome back to All Things Heart. 1 in 8 women will be diagnosed with breast cancer in her lifetime. That is 1 person every 2 minutes in the U.S., according to the Susan G. Komen Foundation. Amy Maple is one of those women. She was diagnosed with breast cancer twice in just 8 years. It returned with new complications, this time to her heart. That's when Amy met Dr. Charlie Porter, who was the first cardio-oncologist in the entire region, and he founded the cardio-oncology program here at the University of Kansas Health System. It focuses on the cardiac care of cancer patients.
And one of the things about cancer emergencies that I've learned, as opposed to cardiology emergencies, you can see a cardiology emergency because people are sick. They've blacked out, they've got chest pain, they're sweating. Cancer emergencies can develop in someone who walks in and doesn't look like they're in distress. They look like they could be a healthy person in as the family member for a sick heart patient.
And let's take a deeper look at what it means to be a cardio-oncologist. Why is heart disease connected to cancer? In some cases, the very treatment that saves your life from cancer, like chemotherapy or radiotherapy, can then later cause heart issues. And you can see here the categories of cardiovascular disorders created by different types of cancer treatment. We are so pleased to have Dr. Charlie Porter joining us today in our studio. His patient Amy is joining us virtually. Amy, you are recovering from a unilateral mastectomy. Amy, how are you doing this morning?
I'm doing well. I feel a lot better now that the cancer is out of my body and that I am, I've recovered nicely, I think.
When was your surgery?
August 27th.
Well, we're so glad you're doing well and back to work, even better. So what happened during your first treatment for cancer that then led you to see Dr. Porter?
The Herceptin that I was taking to help with the HER2 positive cancer, it affected my heart. So my ejection fraction went down pretty low. So they said that I did not need to do the Herceptin anymore. I couldn't do the Herceptin anymore because they were worried about my heart function. And so when I found out that I had cancer again and I knew that it was HER2 positive, that was pretty concerning because I knew that my heart had issues early on. So I sought out someone who could help me to be able to not only fight the cancer, but to save my heart.
Dr. Porter, Amy had heart weakening from a previous drug, a chemo drug. What was that?
Well, she actually had 2 things. She started out with a slight reduction in her heart function from a cardiomyopathy that she didn't know she had. And it was just detected, but her EF was a little, ejection fraction is the amount of blood that leaves the heart. And normal is 55 or up to 65 or so usually. The 50 to 55 is borderline, but she started a little below 50, got some medications, and typically these medications in patients with cancer, they have chemotherapy, they're fragile, and they can't get to these big doses. Mm-hmm. So and she went as far as she could with it, but her heart function went from 40-something down to 25, and with the Herceptin after some treatments, and had to have some Lasix, had kind of heart failure syndrome, and the decision there was made to just stop the treatment, so she had gotten several months of treatment and had gotten radiation. And so it was kind of like, oh, well, it looks okay. Maybe we can just be lucky and stop here, because the heart went down to a level you can't push the Herceptin with. And then breast cancer, being an insidious, nasty disorder, sat there quietly for a while, and you're kind of thinking, you know, it's like a noise in the house at night. You know, you hear it once and you're thinking, well, do I have to go downstairs and dig around? So So we were there, you know, there was just kind of a watchful waiting, and then it came back and still needed Herceptin, and the marker, this HER2 marker, is an indication of a more aggressive, dangerous cancer, which before Herceptin, the HER2 marker was an indication your goose is cooked.
So what's the risk in future cancer therapies when you have this weakness, this type of weakness?
Well, the weakness that she'd had when she'd gotten the best doses of medications that she could get given her fragile state, and her EF still went down from 40 to 25, it was 100%. It was going to happen again. And so Dr. Beakey, who she's seeing in the KU system, sent her to me. She's someone who, you know, was talking about cancer emergencies. Well, she had an emergency because we know that interruptions in Herceptin treatment, if you don't get a year, are associated with recurrence and death risk. And she had already had that. I mean, she had risk, and she'd already had the cancer come back. And the usual stuff had not protected her to allow her to get a full year. So she had a situation where I knew the first time I met her, I could see all this stuff unfolding. She had a weakened heart with something called a left bundle branch block that I knew would respond to advanced pacing, where you could put a pacemaker wire into a certain part of the heart and improve the heart function just from pacing all the time. And so I made arrangements, and she was going to have a chemo port the next day on the right side where we need to put the pacer if she's going to get more radiation to the left side. It's not clear, but once that pacer's in, you can't do radiation if it's on the left side because the port's on the right. So I had to call the surgeon, have them switch the port to the left over here because the radiation doesn't bother the port, plastic, but it does bother the electronics. So, you know, so I called Dr. Beakey, make sure he was on board with all this, called the surgeon. So I spent like 2 hours trying to get all this teed up because part of the emergency was getting the port put in so she doesn't have to go back and have the pacemaker moved, because sometimes you have to move the pacemaker. So I got all that done first day, and then it took a week or so to get her in. I've got really great people. Dr. Pimentel got this pacemaker in quickly ahead of schedule, and Dr. Beakey started breast cancer treatment with Herceptin 2 days after the pacemaker was in. And you know, if you're trying to figure out whether the oncologist thought this was important, 2 days later, I've never heard of anybody getting anything 2 days after a pacemaker. Usually it's like, no way, but he's saying, okay, let's get started.
We got to go.
And that was in April, and she's on board. Amy, I haven't looked at your chart really recently, but you're still on board, on schedule, aren't you?
Yep.
Yeah. So she's going to get another year, and we know that interruptions in cancer treatment increase risk of recurrence. So she's this far. Usually, if you're going to get more Herceptin trouble, it would have shown up by now. And you know, we're not trying to, you know, we don't hold treatment if the heart isn't normal. We hold treatment if the heart gets worse. She's doing really well.
Amy, when you were diagnosed the second time with breast cancer, did you have any idea that you had a weakened heart?
Yeah, I knew that my heart was weakened from when I had the Herceptin the last time, and I knew that that was why they had decided to stop the Herceptin treatment, even though I knew I needed several more months of it. So I did know that I had a weakened heart, and that was really concerning to me when I found out that I had the HER2 again.
Was there something in Amy's genetics that would have put her at a greater risk of this weakened heart?
Not that we know of, but there are. I mean, she had this underlying weakness that she had when she initially started treatment. Might have a genetic predisposition, but right now we have to stay focused on the cancer treatment. That might be something we get to later, but it really doesn't influence things. And you know, right now when you're doing cancer treatment, there's a huge burden just to get in for the diagnoses. I was at an International Cardio-Oncology Society meeting 2 weeks ago, and they were looking at the treatment burden of cancer, and they said that just going in for a lab, I think, you know, I tell people, I'll just pop in for some lab. Well, it's not like you're doing a drive-through to get coffee. You know, the whole burden of just getting blood, and you know, if you've got a port in and bad veins, you've got to go in and get your blood drawn through the port by a port specialized nurse. So it's 2.5 hours just to get, just for what I think is, oh, just get blood. You know, like, you know, it's just like pick up some water for me when you're at the store. Yeah, toss it in the cart. It doesn't work that way. So everything we do is harder on the patient. She's full-time. She's a dedicated teacher. She's in there. Thanks very much. I mean, you know, we've got, she's got her classroom's going to fill up pretty soon, so we can't yak too long.
I know.
But so we're not doing all that workup because it doesn't matter. Number one job, focus on getting the cancer treatment, and then we can worry about everything else later, which, you know, we'll get around to it. But there's just only so many things you can think about, and particularly as a cardiologist, the main event is cancer treatment. So anything I do, because, you know, I'm interested in something, it's just like, come on, let's just get the cancer treatment. So that's what we're eyes on the prize. Get the cancer treatment. Eyes on the prize.
All right. Well, we already have some great questions coming in. So if you have any questions, send them into us on YouTube, Facebook, and the All Things Heart email. You can find links to all of those right there on your screen. So Dr. Porter, I want to go back because, again, I want to go back to this pacemaker. You had the port and the pacemaker for the cancer treatment, but this is the X-ray. This is what you were talking about earlier. Tell us what we're looking at, and again, remind us why the port and the pacemaker have to be on separate sides.
I did one with my crude labeling on there. If you've got that other image to show, that's all me drawing that on.
Like marking like a football move.
Yeah, well, that's just the fun of Photoshop. So you can see the main thing to look at, the shadow. And I didn't really have this labeled as the heart, but there's a shadow. That's a chest X-ray, and a chest X-ray is projected so the patient, as if the patient is looking at you. So left is right and right is left. So you know the heart's on the left side, but it looks like on the right side on this, but her heart's in the right spot. So that big white shadow in the left, to the right of left of center is her heart, and you can see where the pacemaker sits in the chest. Imagine if that were on the left, it's right over the heart. And that is in the area where the breast radiation would be delivered. She's had a little radiation, but there was a question about radiation. But you have to get this stuff taken care of so you don't get mid-treatment and then say, oh, we've got to move the pacemaker, wait for wound healing, blah blah blah. So you can see if that pacemaker were over there over the heart, it would be part of the target zone. They could work around it, but it would still get some scatter, and it's a bad idea. And you can see the port, you can barely see the port over there on the far lateral side, and it's got wires going into the heart. So it's out of the field a little bit. It's a lot smaller target over there, and it's innocuous on the left side.
But a lot going on in there.
So I just had to make sure this got done because when I see people who have a left-sided pacemaker, have left breast radiation, and the pacemaker came far before the cancer, nobody was foreseeing that. So then we have to do that at mid-therapy, and it's just, you know, again, that's just one more thing. People go, come on.
Amy, did you notice a difference how you felt after getting the pacemaker?
Not instantly, just because I was going through chemo and that was making me really tired. And but since I've been off of chemo for a little while now, I feel like I do have more energy. I mean, I'm still tired just from all of the things that my body's gone through over the last few months.
I bet. Dr. Porter, there are a lot of new therapies, targeted therapies that have changed the course of many cancers. Those can also come with cardiovascular risks. How do you identify possible risks for these new therapies?
Well, there's a lot of studies about risk of particular drugs to the heart in the early stages of development. So they kind of weed out the obvious losers. But cancer treatment and Herceptin was the first targeted therapy that really hit the big time. In 2005 was really when its value in early stage breast cancer was recognized and really put a lot more people at risk for that. But the number of targeted therapies where a targeted therapy, it's not chemotherapy, it's targeted to the treatment. Cancer cells are good cells gone bad, and mutations drive the cancer. And different cancers have different kinds of mutations. This HER2 mutation, it's a receptor, protein receptor that gets overexpressed on the cancer cells. It's also seen in other kinds of cancer. Gastric cancer gets treated with Herceptin if they have the mutation. So there are, and there's an incredible amount of work now on new mutations and then new therapies. If you identify the mutation, it doesn't help much unless you have a therapy. So there are hundreds of new drugs out there that are targeted to all sorts of different cancers or targeted to mutations, and the drugs are approved for use against a mutation regardless of what the cancer is. It doesn't matter, because if you shut down that mutation, you shut down the tendency for the drug to keep growing, spreading, or invading tissue.
So is there a certain treatment strategy for the new therapies compared to previous ones?
Yes. Some drugs are identified early as having cardiotoxicity, but a lot of times it occurs later, because studies in heart drugs, there's a powerful drug called Entresto that was in a study that had 8,000 people for several years before it got approved. Well, all these cancers with these mutations, it's smaller groups of people. And there's an advanced therapy that's based on trastuzumab, but it's an antigen drug compound where there's a payload of something else attached to the Herceptin molecule, so it gets in and kind of blows up the cell differently. And it got approved on a study of 800 people, 800 women, because it's a rare form of cancer where they need it. And so then you get to a study where 2 years out, there's maybe 50 people in the study. 2 years out on a cardiology drug, there's still 9,000 patients. So if something bad's going to happen, you know about it. So there's a lot of post-release surveillance. It's called pharmacovigilance studies, where they look at databases and say, okay, now in the real world, we're seeing 15% of something, whereas in the original study of 800 people, we saw 1%.
Yeah,
so part of it is, and I just saw a patient on a drug that initially looked like 1%. Now it actually looks like 25%, and the patient came in after this drug and first had cardiac tamponade where they had a effusion that crushed the heart. Then they followed up in an echo to see if the effusion came back. Effusion was not back, but the heart had weakened down to the level of 40%. So it got a double whammy, effusion, tamponade, and then from the same drug. It wasn't really reported. So these things just happen. You see them.
Speaking of, I want to talk about a powerful therapy, a chemotherapy drug that's been around since the 1960s. It's called Red Devil. Yes, it is red, but it's also one of the most potent FDA-approved chemotherapy drugs. It can also cause serious heart damage. Amy did not take this medication, but Dr. Porter, I wanted to mention this because doctors test patients before using drugs to see the likelihood of what the heart effects might be. But walk us through the testing that's done if you're going to take Red Devil.
Well, the Red Devil is adriamycin, and it's a family of drugs that was first drug that was effective in childhood leukemia in 1967. And they had no idea how much to give, so they just gave a lot. And there was a certain incidence of death, heart failure, pulmonary edema back in the era before they even had an echo. First echo was available clinically in '74, so this was before that. So now it's used only for metastatic disease or leukemias. So because it's got too much toxicity to use when there's other options, and it's used less and less in breast cancer because we have other targeted therapies, a variety of therapies that can be effective, as effective as adriamycin. But everyone who's going to start adriamycin gets an echo, and this is another cardiac emergency. People come in, get the echo, and then the echo shows an EF of 40%. And one of the first challenging cases I saw several years ago was a 40-year-old mother of two who was full-time as she was working in finance, CFO, smart person, noticed something lump up in her collarbone, gets it looked at, she finds out she has a lymphoma, and the lymphoma is encircling her carotid, the artery going to her brain. And she got an echo, she got 2 tests, her EF was low, 40%. I saw her on Tuesday. They want to start chemo, adriamycin on Thursday. So I did what I could then to protect her heart, and we know more about how to do that now. But I just said, we're going to go ahead and give you the best protection we have available, because between now and a year from now, your greatest risk of having something terrible happen is to let this lymphoma go inadequately treated. And she had a cardiac surgeon in her family, so I did a teleconference and I was explaining these risks to the cardiac surgeon, cardiac surgeons take care of high-risk people all the time. She just said, do it. You know, she knew what I was talking about. You're talking about risk versus benefits. Safer path, get the cancer treatment. So we do that, and now there are other things we can do for adriamycin. Some things are outside FDA regulations, but there's enough evidence to support them that I can say, we're doing this, I don't care what the FDA says. It's between you and me. I'm telling you this could happen or this happened. And nobody wants to die of cancer, but they have the comfort of knowing their ejection fraction is 55% instead of 40. Who cares? You know?
Let's get to some questions from our viewers this morning. We've got some good ones coming in. Yang says, could undergoing chemotherapy and related treatments for breast cancer harm heart health given how close they are in the body?
It's not really proximity except with radiation. But techniques for radiation now are getting very, very good. And no one in this country should be getting radiation for left breast cancer without being instructed to do deep breath hold, because there's lung, you don't really think about it, I didn't think about it before this, but there's lungs sitting between the heart and the chest wall, and you know the breast curves around the chest wall from the front, the heart kind of sits in the curve from the back, so they're all in the same neighborhood. But when that lung tissue expands, the lung expands and pushes the heart back, so it moves out of this curve in the chest where it kind of tucks in on the left and gets out of range. So then the radiation beams can be broken down and targeted away from the heart. That's a huge reduction in risk. And then proton, there's other things that they do, and there's a lot of different techniques where they can do different beams. You could have a radiation oncologist on it for a cancer show there, but there's a lot of different techniques to really reduce the risk of radiation, but it's not zero, and even right breast radiation does carry a small risk to heart on the left.
Jeremy says, I imagine that it's a hard line to walk between the benefits of cancer treatment outweighing heart risk versus when a heart risk is high enough that a cancer treatment isn't an easy call. Do you have a rule of thumb or common things that help you know which way to go?
Yes, it's just, you're just looking at relative risks of the natural history of the disease, and this is where a lot of what I do is shoulder to shoulder with the cancer people, and that's really what I love about working here, is the oncologists are really good about communicating and looking at this as team. And I talk to oncologists all the time. I talked to Dr. Toon yesterday on 3 different cases. He called me for 2, and I called him for another one in the evening. So we work together because I have to know if the oncologist believes a treatment is necessary enough to warrant taking some risk. And then I have to understand what things I can do to reduce the risk, and then look at whether or not the risk as it's reduced is low enough that we can continue the cancer treatment.
Makes sense. Alex wants to know, is it always breast cancer patients who need a cardio-oncologist? Are those the bulk of Dr. Porter's patients?
No, it's not. It used to be. In 2015, I pulled a talk that I gave in 2015 about cardio-oncology, and I said there were 4 drugs. I've got a slide on this. You know, so I'm looking at the range of cardiotoxicities. I had 4 drugs: adriamycin, red devil, Herceptin, this 5-FU, which can cause chest pain, and some of the drugs for renal cell cancer, VEGF inhibitors that cause hypertension. That was it. Now, if I'm showing a slide about cardiotoxicities, I can't even show one slide. You can't read it. You know, it's a couple of slides, and there are these exploded diagrams because there are so many new drugs out and combinations of drugs and different types of toxicities that didn't even exist in 2015. So it's just blown up, and it's still. I mean, every day. I mean, the only weeks where I don't see somebody with a new drug that's first in human or something, first application, is on vacation weeks. I live with. I mean, I Google stuff all the time because I say, it's new stuff. So I have to just find out what cases of 15 other people in the world are in the same situation as my patients, because KU is a Comprehensive Cancer Center, so they're getting the newest drugs, and some of the doctors, or some of the KU protocols are developed here. So I'm seeing all these things that are right at the leading edge, and they just count on me to kind of figure out how to stay in the game.
Amy, I want to get back with you because I know you've got to get going this morning and get to your kids who are going to be flooding through those doors here in just a second. So I just want to ask you what your final thoughts are. What do you want folks to take away from your story?
Just to be an advocate for yourself and make sure that you are getting the best care possible. I'm thrilled that I was able to meet Dr. Porter and that he was able to help me to get through both the cardiac issues as well as the cancer issues, because without him, I don't know where I would be. I don't know if I would have had to pick, do I save my heart or do I save, my life from cancer? So I feel like just being an advocate for yourself and getting the best treatment that you can possibly get.
Great message. Thank you again for sharing your story, and just be well. Thanks, Amy.
Thank you.
So Dr. Porter, what do you see as the future of cardio-oncology?
It's part of the future of cancer treatment, and it's a future of the program in cardio-oncology. I mean, part of my efforts are just to be able to prepare the infrastructure to get this beyond what I'm doing. I've got a colleague who has been working on learning cardio-oncology with my mentorship for about 3.5 years, Dr. DeCordy, who is really making remarkable strides in just picking this up, because I have the advantage of started reading about this in 2005, so I've been there as the field developed. But people coming in who just say, I'm interested in this, they're in deep, cold water, and there are lots of different things. So I just need more people. I've worked 3 years to get a recruit who's fellowship trained, Raja Zaglul, and he's at Barnes right now finishing up his training. But he's coming in. I just was able to add a PhD basic science researcher so that we can contribute some of the basic science things. And so it's, there's a world of research that we're trying to expand to be able to do. And then the clinical care is just beyond the capacity for 1 or 2 people to manage. So I see a lot of growth and a lot of more conversations with the cancer doctors every day.
I bet. All right. Thank you just for being here and sharing your expertise and introducing us to Amy. Of course, while we love sharing the incredible work of our doctors here at the health system, have you ever wondered what your doctor does outside of work?
Now for a secret look into the guardians of healthcare at the University of Kansas Health System. Let's go behind the mask.
Okay, Dr. Porter, you joined us last week. You shared some beautiful images that you took. You have some more. Tell us about your passion for photography. Tell us what we're looking at and where you went.
Well, I started in photography the same time I started my career in medicine at KU. I joined the Jayhawker MD yearbook staff because I didn't know a soul up here. I thought I was going to go to a different med school, and I changed it to KU for a lot of different reasons. So I learned photography, and some of my best friends have stayed the people who stuck with that, including someone who has become an avid hiker, Dr. Mike Schoenlieber up in Minneapolis, and he recruited me to go to the Alps to do a tour of Mont Blanc, where you do a hiking tour around Mont Blanc.
You said 32,000 steps you did that day?
Yeah, so
and
yes.
Tell them about the kid that asked to take a picture with you.
Oh yeah, well, so you're up in the Alps, and I mean we were up in mountain trails, and I really didn't have any idea if it were something in medicine. You get informed consent, so people tell you exactly what's going to happen and what the risks are and how you're going to feel. Nobody gets informed consent. Mike said this will be really cool, once in a lifetime. I didn't ask any questions, and I thought I was going to be walking around in fields, going around Mont Blanc, looking for where Julie Andrews sang the Sound of Music. And instead, I'm up on these trails, which are wet rocks in the rain, blowing wind. We're hiking into the clouds with hiking poles, trying to go up I didn't know. My iPhone told me I took 32,000 steps in one day, and that I had gone up 5,000 feet and then back down. And in the mountains, doing that hiking, going down is no easier than going up because you've got the momentum. You've got to brace yourself. So these hiking poles. So I'm doing all this, and so then I get around and I'm noticing there sure are a lot of young, thin people going by me. And then I got to the top of this one ridge that we'd worked on for like 4 hours, and you can't stay up there because you got to get back down. So I'm up there. We're short on photos for that stuff, but there was, 5 guys, British accents. I thought they're from UK. They said, "Hey, let us take our picture with you. You're older than our parents. We can't believe you're up here." So, and that's the way
They
it
needed
was.
photographic proof that this guy is up here doing this.
Go back and shame their parents, I guess. I don't know, but I was just
Good
happy to be able to do that, and I'd never talked to anybody who had 32,000 steps in a day.
Either. You're my first right here.
Yeah, I mean, it's like, God, I don't know, I got to do it again tomorrow.
Well, that's walking the walk. You're a heart guy. I think you just got your heart health in.
Yeah.
So good for you. Thanks for sharing that. We're glad you got down safe.
I am too.
All right. Thank you to all of our guests for being with us. Thanks for being with us today on All Things Heart. An incredible edition for cardiac patients coming up next week. Also, their doctors. How a new robotic heart lab is a game changer for patient care. That's coming up Thursday at 8. Coming up tomorrow on the Morning Medical Update. Breast cancer caught just in time. Tracy Caton's routine mammogram likely saved her life. I'm Jessica Lovell on the next Morning Medical Update. A simple screening that led to tough decisions, including how to keep the cancer from coming back. Friday at 8.